10 to 20% of breast cancers diagnosed in the United States are what are called triple-negative breast cancers.
And on this week's Health Talk, we'll be joined by top breast cancer doctors who'll discuss this unique type of breast cancer, including the risk factors, diagnosis, and treatment options.
So stay tuned. Health Talk is up next.
Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Joining us on Health Talk today are Dr. Linda Vadat. She's the Director of Cancer Services at Norwalk Hospital, and Dr. Richard Zelkowitz. He's the Medical Director of the Smilo Family Breast Health Center at Norwalk Hospital.
Rich, please tell me something about the new collaboration between Norwalk Hospital and Sloan Kettering, and how they're working together, and what that means for Norwalk patients.
So this is a very finite relationship, and what I mean by that is there are memorial doctors now at Norwalk, and the Norwalk doctors will also be participating at Sloan Kettering, either at the West Harrison office or in New York City. This will allow our patients to have care locally that's available in the city, and if something is not available here, they'll have a conduit right into the city to Memorial.
Linda,
so it's the best of both worlds.
What a great opportunity to have patients be able to really continue to receive world-class care right here in their own backyards.
We're very excited to be a part of this whole initiative. I've worked with the Norwalk radiation doctors and medical oncologists for many, many years, not quite 2 decades, but close to it. And I couldn't be more excited to be working with them closely to bring some of the resources that we have at a world-class institution like MSKCC out to Norwalk Hospital, and to really increase the integration that we have.
So here at Norwalk Hospital at the Whittingham Cancer Center, we'll be following Sloan Kettering protocols, and we'll be doing the same kind of radiation treatments that is available in the city. Is that correct?
Well, I mean, the Whittingham Cancer Center has wonderful protocols, and I think that there's always an opportunity to improve oneself. And I think areas that we may want to improve will look towards an institution like Sloan Kettering to see how they approach a particular situation, and perhaps we can adopt some of their some of their policies, some of the way they do things, both in medical oncology, radiation oncology, supportive care, lots of different things. The thing is at Norwalk Hospital at the Whittingham Cancer Center, it is a great cancer center, and now we're just looking to leverage the resources of Sloan Kettering to make it a world-class cancer center.
Well, it's very, very exciting for the folks here in Fairfield County. I think it's the future of cancer treatment. It's just great to have you here in Norwalk, and to have Rich, I know you've been doing this for 20 or 30 years, so this is not new for you, but it sort of formalizes what's been going on.
Yeah, the majority of cancer care is actually in the community. So this is a win-win on both ends. It offers options that we would not have had previously had before.
Now, Linda, part of what we want to talk about in this show is what's called triple-negative breast cancer, and you're an expert in treating patients with this. What does that mean? What is that?
That's a good question. What does it mean? So triple-negative breast cancer is really about 7 or 8 different subtypes of breast cancer. Represents about 17% of all women who are diagnosed with breast cancer. However, it represents a disproportionate number of women who have metastatic breast cancer. Probably close to 50% of women who have metastatic breast cancer have triple-negative breast cancer. And it's sort of characterized in a very loose way as tumors that do not have the HER2/neu receptor, which is a growth accelerator, and doesn't have hormone receptors. And what really characterizes triple-negative breast cancer is that there are many less treatment options than we have for the other kinds of breast cancer that we take care of.
Yeah, we've known for years that breast cancer that expresses certain hormone receptors responds to the addition or the subtraction of female hormones. So triple-negative doesn't respond to those hormone changes?
No, so triple-negative breast cancer is hormone receptor negative. So that means it doesn't use estrogen to grow. So therefore, we wouldn't take the estrogen away in order to shrink things down.
So tell us something about the unique features and how you're approaching triple-negative breast cancer.
So triple-negative breast cancer, there are a couple of different ways that we approach it. Certainly when someone has breast cancer that's spread, they have metastatic breast cancer, so it spreads somewhere outside the lymph nodes in the neck. Then what we have a couple of brand new drugs. We look for new strategies to try to treat them. We've been working with a lot of really exciting brand new drugs. One of them is a drug called IMMU-132. It has breakthrough status from the FDA, and I'm really excited that we're going to be getting that up at Norwalk Hospital in order to treat patients who have triple-negative breast cancer in our community. So that's very exciting because...
Rich, yeah, I was just going to ask, Rich, will you be sharing or specifically referring the triple-negative patients to Linda?
I think this is a collaborative effort, so I think people will probably stay with their primary oncologist, and we'll put our heads together and offer the best option. You know, we classically have only been able to offer those patients chemotherapy because it's not responsive to hormones and it's not responsive to the HER2 therapy. So this will give us a different option. And
But Linda, you've been doing this for years, and this is really, you're nationally known or world known for your work in triple-negative breast cancer.
So we're very excited to bring those programs up here to Norwalk Hospital, as well as there's a group also at MSKCC which is also very interested in triple-negative breast cancer, but looking at it from a different perspective, looking at something called the androgen receptor. So we know triple-negative breast cancer doesn't have the estrogen receptor, but there's another hormone receptor called the androgen receptor, and they have a whole series of clinical trials and access to drugs targeting that. So that's something that we're also going to have access to, which is going to be pretty exciting for us. But one of the things that we're really interested in with triple-negative breast cancer is that our goal is to prevent it from spreading. And thinking along those lines, we have a number of therapeutic strategies that we think can perhaps prevent that. And we're looking to get those clinical trials open and make them available, in the backyard of the people who live in Norwalk.
I think that's really wonderful. And Rich, it really highlights something that I'm not sure everyone fully appreciates. We talk about a cancer as if all cancers that come from one organ, like the breast, are all the same, but they're really not. There's a lot of heterogeneity in cancers that even can come from the same place, but from person to person. And so these kinds of advances really are quite exciting.
Yeah, anytime we can find a target, we can usually make more effective therapy with less toxicity. We can direct our treatments towards specific entities, and that is obviously of advantage. We've seen that with estrogen receptor positive tumors because all the hormones are in essence a targeted therapy, and we see that with the HER2 positive tumors. So this is an exciting thought process or option for these patients.
And Linda, it sounds like this also means that cancer care and care for triple-negative breast cancer is very individualized. It's really about trying to treat exactly that one person who has this cancer.
Treatment for metastatic breast cancer and triple-negative breast cancer is extremely individualized. I mean, it starts with sequencing the tumors, having an idea about what are the drivers that made it spread, and then coming up with strategies which hopefully target those therapies and to get good responses.
And pretty routinely now, when we see a patient who we suspect has metastatic disease, we are sequencing those tumors, which is also generating more data and more information and more options.
Yeah, that's really a remarkable change in oncology, is that we're now getting such detailed information about each individual's specific cancer. And maybe, Linda, you could say a few words. You talked about drivers, which is probably an unfamiliar word to folks at home. And we talk about the microenvironment, we talk about the immune system. There are different strategies to get at cancer. Maybe you could explain those generically a little bit further.
Yeah, so when you talk about the tumor microenvironment, what you have to think about is that tumors don't come with their own infrastructure. What they do is they hypnotize all the cells around them to do their bidding. So maybe let them their defenses so that they can spread. Tumors think about it as a single cell. When it spreads, it doesn't even know how to get from point A to point B. So there are cells within the body that it co-ops that leave a popcorn trail for a tumor cell to follow to a distant metastatic site. Once a tumor gets to that site, what happens is that it can't get into an organ, goes to the liver or the bone. Things have to be sort of conditioned so that it can land there. So you have a landing pad formed by collagen that tumor cells land on. And then the tumor cells land on this landing pad when it spreads someplace, and it doesn't have blood vessels to sort of help it grow. Now, blood vessels are really important. We've probably heard about angiogenesis. Your viewers have heard about angiogenesis, and that's the process by which blood vessels come in and basically are the superhighways that bring nutrition in. But then what they are, they're the superhighways by which cells can detach and spread to other places. So we know that by interrupting each step of these processes that you can certainly get tumor shrinkage, But we know that by inhibiting each of these steps that we haven't been able to prevent the spread. So perhaps sort of like a cocktail approach is what you need in order to truly prevent tumor spread.
It's really fascinating. And Rich, going from kind of the micro details to the macro details, taking care of a patient with cancer, though, is much more in some ways than just making sure you have the right treatment protocol or the right medication, isn't it? That's why we have a whole cancer center that's very multidisciplinary to really take care of the whole person while they're going through this.
Yeah, I think we all know that we need a village for this. It's not one person, and there are different needs that we all can't meet, and we try to do that. We try to have a multidisciplinary approach, and everybody brings something to the table to make the situation a little bit easier and more effective for the patient.
And I think that includes integrative therapies, doesn't it?
Yeah, so we have an integrative program, and we have a palliative program at the hospital, and we obviously have a very strong radiation and medical oncology program, and we have very, very good support. So it's all these things that go together to make this journey for the patient a little bit easier.
And we only have maybe a minute and a half, minute left. Where do you see the future of breast cancer therapy going in the next, and the time frame, 5 years, 10 years?
So I think the future of breast cancer therapy is that it's going to be completely targeted. I think that screening is going to prevent, because you're going to have, you take a drop of blood, put it on a piece of paper, it's going to tell you exactly what you need to know in terms of someone has cancer or not, even before they know they have cancer. Then it's going to be profiled, and you're going to get a treatment which is going to prevent perhaps, the initiation and subsequently the spread. I would say it's probably just like Star Trek.
And do you think
So
we'll
exciting.
see this? I mean, I've heard people even think that we'll see this within 10 years, the control of most cancers within that period of time.
So I don't think you could just speak in terms of most cancers, because I think that's very heterogeneous. But I'd like to think, after having done this now for 29 years here, that when I retire, there'll be no more breast cancer, and that would be great.
What a blessing that would be.
That would be.
Pretty exciting times in the world of cancer.
Yep.
Really amazing.
Thank
Considering
you.
the field only developed when, in the 70s or 80s, it's a remarkable progress.
Well, think about, they used to do radical mastectomies, which were truly a disfiguring operation. Now they do nipple areolar sparing mastectomies. And I have to tell you, with some of these surgeries, these women could be on topless beaches and no one would know that they had
That's
bilateral
amazing.
mastectomies. I'm serious. So, I mean, just even from the surgical perspective.
Absolutely, and so important.
Yeah.
Thank you both so much
Yeah.
for being on our
Thank
show
you.
to share such important information with our viewers. We appreciate it. And unfortunately, that's all we have time for today.
So please email your questions and comments to Andrew and me at healthtalk@wchn.org. We'd love to hear from you.
We'd like to thank our guests today, Dr. Linda Vadat and Dr. Richard Zelkowitz, for being on the show with us.
Thanks for watching, and this is great news in the cancer world.
Be well.